On 3-2, the patient will receive a tracheostomy procedure because the patient had been ventilated for 2 weeks and the patient was not responding to spontaneous breathing treatments. The patient was considered to be in respiratory failure with a history of COPD, and the family informed consent for the tracheostomy procedure on 3-2. There was no intraoperative complications that occurred, and the patient would be medically ventilated through the tracheostomy after and would be transferred back to the ICU. A tracheostomy procedure is a surgical procedure that creates an opening through the neck into the trachea or windpipe, shown in this picture, and this allows direct breathing through the tube. Breathing is done through the tracheostomy site versus the nose or mouth. On 3-4, the patient was finally allowed to be on total enteral nutrition versus TPN with trickle feeds. The medical status of the patient had improved after the ileus was resolved and the tracheostomy procedure was performed. Pharmacy signed off and nutrition was consulted for tube feeding management once again. At this time, the tube feeding formula was changed, and the formula was changed from osmolate 1.5 to osmolate 1 cal, which is a slightly less concentrated formula, and the patient had a goal rate of 65 milliliters per hour infused again over 22 hours. At this time, the patient's nutrition problem and intervention had changed, and the patient's current problem was inadequate EN infusion because the EN infusion had not been reached to goal, or the scheduled infusion was interrupted secondary to her high gastric residuals, and ileus or small bowel obstruction was possible at this time. The patient had signs of inadequate EN volume compared to estimated needs, and at this time the patient's goal remained the same: to meet estimated nutrition needs through enteral nutrition. However, on 3-9, the patient was not progressing towards goal, and the inadequate EN infusion problem remained the same. At this time, the patient was not receiving enough EN nutrition, and this was because there was a possible hernia. The patient was not meeting estimated needs through her EN nutrition. The patient was sent to IR to receive a PEG tube, and the patient was found to have a ventral hernia. The patient was going to receive a PEG tube because at this point the patient needed long-term nutrition support because the patient had just received a tracheostomy and there would need to be a lot of physical therapy before the patient could eat orally again. The patient was also experiencing diarrhea and was tested for C. diff. On 3-10, the hernia was repaired and the PEG tube was placed. The patient's problem and intervention on 3-11, the patient resumed osmolate 1 cal. However, there were still some gastric residual volumes, way less than the previous problem with gastric residual volumes. At this time, the gastric residual volumes were between 70 and 150 milliliters, which the protocol for gastric residual volume, which most literature articles will state, is that gastric residual volume of 250 milliliters or greater should be the only time when tube feeding should be held, because the stomach can have up to 250 milliliters of gastric juices at any time. However, the doctors felt that the patient was already at risk for malnutrition because of the previous gastrointestinal problems, including diarrhea. So the patient would be a candidate for an advancement from a PEG tube to a PEG-J tube. This way, the patient's tube feeding would bypass the stomach and prevent any gastric residual volumes that could recur because the tube feeding would end in the small intestine. The patient's tube feeding was now going to be changed to a Vito 1 cal, which is a more elemental formula, which is pretty much digested already. So having the tube feeding end in the small intestine with an elemental formula would hopefully prevent any more gastrointestinal problems. As I said, Vito 1 cal would be the formula chosen for this patient at this time at a goal rate of 65 milliliters per hour infused over 22 hours. Vito 1 cal is an advanced hydrolyzed protein structured lipid formula with prebiotics to support tolerance. The patient is suitable for impaired GI function or malabsorption, which is definitely this patient. On 3/12, the patient's PEG tube was advanced to a PEG J tube and the tube feeding was restarted at Vito 1 cal. Finally, the patient was healthy enough to begin discharge orders, and the patient received her PEG J tube, and her tube feeding was resumed at Vito 1 cal. At this point, case management helped find the patient a bed at Select Specialty Hospital, and the patient would be discharged using a tracheostomy ventilator and would be on tube feeding. From literature, for this particular case study, the Nutrition Care Manual bases all recommendations for nutrition support on evidence-based practice from literature, and these evidence-based recommendations were used when treating this particular case study. Both Aspen and ESPN suggest that EN nutrition is the first protocol for nutrition support, and PN should be used as an alternative or an additional approach when other methods are not succeeding. Most clinical literature suggests that EN through the GI tract is the best method for nutrition support to maintain gut motility. And for all the scientific articles that I researched, these were the main recommendations for nutrition support in critically ill patients. Most of the literature suggested that these 3 items were the most important when feeding a patient EN support in the critically ill setting. Also shown in my scientific literature review was that this particular patient had extremely high gastric residual volume, and literature suggests that high gastric residual volume, that this should be checked every 4 to 6 hours if there is EN nutrition through a pyloric enteral tube. If the tube is post-pyloric, for example, a DAWPOF or a PEG-J or a J tube or an NJ tube, then gastric residual volume should not be checked. If gastric residual volumes are greater than 250 milliliters, literature suggests that tube feeding should be held until the problem is resolved. All of these topics were the main items researched and suggested when I read my scientific articles for this presentation. And these are my references.